Good evening, consultants, senior registrars, and registrars here present. I'll be making a presentation on principles and management of viral hemorrhagic disease. My name is Dr. Pascal. Uchena. There are diverse groups of animal and human illnesses that may be caused by the five distinct families of RNA viruses. But we're primarily looking at the Lassa fever, which is a family of the arenaviridae, the Ebola virus from the family of filoviridae, the yellow fever and dengue virus from the families of Flaviviridae. What are the clinical features of hemorrhagic fever, viral hemorrhagic fever? All types of viral hemorrhagic fever are characterized by fever, bleeding disorders in the form of flushing of the face and chest, small red or purple spots known as peteche, frank bleeding. Other non-specific symptoms are muscle pain, headache, vomiting, and diarrhea or disease which occur more frequently. This patient can present from high fever and develop shock and death in many cases. Other general symptoms depend on the specific type of viral hemorrhagic fever, and also the severity of symptom varies with the type of virus. Now, there are several mechanisms that contribute to symptoms, which include liver damage, disseminated intravascular coagulability, which leads to blood clots formed in the blood vessels through the body, removal of platelets necessary for clotting from the bloodstream and reducing clotting ability. DIC, which is disseminated intravascular coagulability, is thought to cause bleeding in Ebola and Marburg fevers and also lead to bone marrow dysfunction. The reason for variation among patients infected with the same virus are unknown, but stem from a complex system of virus host interaction. Now, for diagnosing viral hemorrhagic fever, distinctive diagnosis is usually made at a reference laboratory with advanced capabilities. The findings of laboratory investigation vary between the virus, but in general, there is decrease in total white blood cell count, particularly the lymphocytes, decrease in the platelet count, there's increase in blood serum liver enzymes, there's reduced blood clotting ability, measured as an increase in both the prothrombin time, the activated partial thromboplastin time. The hematocrit may also be elevated. The serum urea, erythroid, and creatinine may be raised, but this is dependent on the hydration status of the patient. Bleeding time tends to also be prolonged. Now, how do we prevent the spread of viral hemorrhagic fever? The guidelines detect that all viral hemorrhagic fevers, with the exception of dengue fever, should be cared for using strict contact precautions, which include hand hygiene, wearing double gloves and gowns, shoes, and leg coverings, face shield or goggles. Lassa, Ebola, and Marburg viruses may be particularly prone to nosocomial spread in the hospital environment. Airborne precautions should be utilized. A positive pressure supply air respirator should be worn by personnel coming within 6 feet of a viral hemorrhagic fever patient. Environmental decontamination is typically accomplished by hydrochlorides or using the bleach. Now, the viral hemorrhagic fever of interest we're discussing is the Ebola virus, the yellow fever virus, dengue fever virus, and the Lassa fever virus. For the Ebola fever virus, which is named after the Ebola River in the Democratic Republic of Congo, formerly known as Zaire, near the location of the first epidemic. The two species identified in 1976 are the Zaire Ebola virus and the Sudan Ebola virus. A third species, known as the Reston Ebola virus, was discovered in November 1989 in a group of monkeys imported from the Philippines. We also have the Ivory Coast Ebola virus, but which is not very common. Now, the natural habitat of this Ebola virus is actually in Africa, spanning between the Democratic Republic of Congo to Sudan to Gabon, Ivory Coast, Uganda, and even a few we've gotten in Nigeria. The source of infection are non-human primates, which are thought to be the source of human um, infection. Ebola, Ebola fatality rate is right, the Ebola of Sudan and that of Zaire is estimated to be about 60%. Ebola Zaire is about 77 to 89 to 88%, which is actually the highest. Ebola rostrum found in monkeys has not shown to be fatal in humans. However, why Ebola and Democratic Republic of Congo, only one human case has been recorded so far, and and also, the patient also survived. For the ongoing outbreak, as of August 15, 2014, um, the total cases, which includes suspected and confirmed case count, was about 2,127. Suspected cases was about 1,145. Laboratory confirmed case was about 1,310. For the regions where we had the outbreak, Guinea, suspected and confirmed case was 519. Suspected, suspected case death was 380. Laboratory confirmed cases was 390, 376. In Liberia, suspected and confirmed cases was 786. Suspected case deaths was 413. Laboratory confirmed case was 190. In Sierra Leone, suspected and confirmed case was 810. Suspected case death was 348, while laboratory confirmed case was 733. In Nigeria, which is the fewest, suspected and confirmed case was 13. Suspected case death was 4, and laboratory confirmed case was 11. These are the modes of transmission the Ebola virus can get into the human species with through unsterilized needles, hospital contagions when you come in contact with hospital fomites, and person to person contact, person who is infected with it. Risk of exposure to Ebola virus is when infection occurs in humans. There are several ways in which the virus can be transmitted to others: through direct contacts with blood or secretions of an infected person, exposure to objects such as needles. The virus that cause hemorrhagic fever are often spread through families and friends due to close contact with secretions of an infected person. During outbreak of Ebola virus, the disease can spread quickly within healthcare settings such as clinics and hospitals. So the early symptoms of this virus is fever, nausea, headache, and tiredness. You can also have joint pains, stomach pain, lack of appetite, rash, red eyes, hiccups, sore throats, and even difficulty in bleeding. You can see from the picture here represented, you can see the red eyes and the rashes. And then some of the late symptoms are vomiting, which may contain blood, diarrhea, which also may contain blood. Patient can also be coughing out blood, and then bleeding from orifices such as the mouth, nose, penis, vagina. And then some the late presentation, of course, bleeding from everywhere, you can see bullous skin and lesions, and then DIC. Incubation period for Ebola virus is from 2 to 21 days after exposure. to Ebola virus, though 8 to 10 days is the most common. Ebola virus disease is only infectious when symptoms have developed. So it means that when symptoms are not, patient has it's not already, has not already presented the symptoms, patient is not infectious at that stage. Diagnosis of Ebola virus when infection is just recent is difficult because the early symptoms such as red eyes, fever, skin rash are non-specific to Ebola virus infections and are seen often in patients with more commonly occurring disease. Now, clinical picture, patients with Ebola virus present with fever, when you see fever of 38.6 degrees Celsius, additional symptoms such as headache, muscle pain, vomiting, diarrhea, and blood, abdominal pain, unexplained bleeding. This could be a pointer. Epidemiologically, contact with blood or other body fluids or human remains of a patient known to have suspected uh, suspected, suspected a case of Ebola virus, and also close contact with patient with Ebola virus disease, patient who is resident or have traveled to an area where there is Ebola virus disease transmission, direct handling of bats, rodents, or primates from disease epidemic areas, where the above parents has where the above experience has occurred within the previous 21 days before the onset of symptoms is a good is a is a risk factor. As a result of biosafety level required in the handling of samples from Ebola virus, it has been recommended that tests should be carried out only at designated places. So, investigations carried out are nucleic acid hybridization and ELISA. Also, electron microscopy can provide definite evidence. We also have the PCR. We can also have the viral culture, which is actually the gold standard for diagnosis. Now, treatment, there is no known definitive treatment or cure for Ebola virus disease. However, sick people are given supportive therapy, which are treatments that help them become more comfortable but do not cure their illness. This often include IV fluid, supplemental oxygen, and antibiotics if the person has a bacterial infection occurring alongside with the Ebola virus in designated isolation centers. Ebola virus itself cannot be treated with antibiotics because antibiotics do not work on viruses. Strict isolation precautionary measures are required, including the use of personal protective equipment by healthcare personnel who attend to cases. Now, it is important part of also the treatment and prevention, which is the responsibility of the medical care at designated centers, which include surveillance, promote awareness about the Ebola virus disease, educate on Ebola virus prevention, identification of suspected cases, notification of the designated centers from where the process of transfer is arranged. And it's also very much important that healthcare providers protect themselves by handling suspected cases, wearing gloves, gowns, aprons, cover shoes, eye protections, and face masks, especially when you come in contact with these patients or suspected cases. Also, there is no vaccine for Ebola virus prevention. So avoid Ebola virus disease high risk activities such as close contact with suspected cases, handling bodies of people who have died from Ebola virus, caring for Ebola virus patients, attending their funerals or burying their bodies, touching bodily fluids or objects contaminated with fluid from Ebola virus disease. Do not handle animals or bats even if they seem healthy. Do not eat bats or bushmeat from gorillas, monkeys, and other primates. These are very much important to prevent Ebola virus disease. Also, it's also good we clean our hands regularly and regular use of hand sanitizers in our workplaces and in our homes. For vaccine in June, Jones and his colleagues, namely Dr. Hans Fieldman of Whipping and Dr. Thomas from Maryland, announced that they have successfully vaccinated monkeys against the deadly viral virus. The Ebola vaccine is based on the 1976 strain of the Zaire species from Congo, which protects from 1995, but not the other species that affect humans, meaning that just the Zaire that were able to experiment on the vaccine so far. For yellow fever virus, which is primarily transmitted by mosquitoes, is an acute viral hemorrhagic fever transmitted by infected mosquito, basically the Aedes aegypti and the Hemorrhagic species. There are estimated 200,000 cases of yellow fever, causing about 30,000 deaths worldwide each year. The virus is epidemic in tropical areas of Africa and America, with a combined population of 900 million people with this disease. The, the geographic range of the virus in South America and Africa, there have been no reported case in Asia, probably due to the high incidence of dengue fever, which helps confer immunity against yellow fever. In Africa, an estimated 508 million people live in 52 countries, which are at risk of this virus. There are an estimated 200,000 cases of yellow fever, causing 30,000 deaths worldwide each year. Benjamin Rush was the first to recognize the disease as yellow fever. He also identified the stages of yellow fever transmission based on the history. Yellow fever virus is assumed to have originated from East or Central Africa and probably brought to South America by ship after 1492. The first outbreak of the disease was in 1648 in Yucatan, where it was termed Zekik, which is for patients were beginning to have black vomit at that time. So they named it Sekik. The last major outbreak occurred in New Orleans in 1905. In 1881, Carlos Finland, a Cuban doctor, first proved that yellow fever is transmitted by mosquito and thus is controlled. The Nigerian situation in Africa, the largest number of cases was reported from Nigeria. From 1984 to 1993, Nigeria reported over 20,000 cases and 4,000 deaths. In May and April 1987, an epidemic of urban yellow fever occurred in Oyo State. The primary vector was Aedes aegypti. A total of 305 cases and 415 deaths were recorded. In 1994, there was an outbreak in Imo State which spread to the neighboring districts of Cameroon. The last cases were reported in May 2001 in Kano by the Federal Ministry of Health. And as of 2006, immunization coverage of yellow fever in Nigeria was 51%. Map showing yellow fever epidemic zones in Africa as of 2009. The mode of transmission is via the bite of an infected female Aedes aegypti mosquito or the Hemorrhagic species. Non-human and human primates are the main reservoirs of the virus, with anthropootic transmission occurring. Bloodborne transmission can also occur given the high level of viremia attained in humans. There exist three transmission cycles that for yellow fever, which named the Sylvatic, Intermediate, and Urban. For the Sylvatic cycle, which is a jungle cycle, also known as jungle cycle, virus transmission between non-humans. This is virus transmission between non-human primates and mosquitoes in the forest canopy. The intermediate savanna cycle is the virus transition from three whole breeding mosquitoes. This is mosquito to humans. In this cycle, the virus may be transmitted from monkeys to humans via mosquito. Urban cycle, this is transmission of the virus between human and urban mosquitoes, primarily Aedes aegypti. Yellow fever can follow as an idiosyncratic reaction from yellow fever vaccination, but this is very rare. What are the clinical features? Incubation period of this virus is typically 3 to 6 days. The acute phase of presentation includes fever, muscle pain with prominent back pain, headache, loss of appetite, nausea, vomiting. Most patients improve after this initial presentation. However, 51% of patients enter the toxic phase, characterized by jaundice, hemorrhagic symptoms such as bleeding, and eventual shock, leading to kidney dysfunction. Half of the patients who enter the toxic phase die within 10 to 14 days. The rest recover without significant organ damage. Overall case fatality rate for yellow fever with jaundice is 20 to 50%. Those are some of the symptoms I presented earlier. Now, for the complication of yellow fever could be coma and death, this DIC, kidney failure, liver failure, parotitis, and also secondary bacterial infection and shock. How to diagnose this? A person with advanced yellow fever may show signs of liver failure, renal failure, and shock. However, if you have symptoms of yellow fever, it's important that you tell your doctor if you have traveled to area where the disease is known to thrive. Blood tests can confirm the diagnosis. Preliminary diagnosis is based on the patient's clinical features, places, and date of travel and activity. So it's important that we take a very good history. Laboratory diagnosis is by testing serum to detect the virus, immunoglobulin M, and immunoglobulin G antibodies. Tests can also include neutralization tests for antibodies, indirect fluorescent antibody tests, ELISA, and PCR. There is not specific treatment for yellow fever, only supportive care to treat symptoms like fever and also rehydration and dehydration rather. So important to know that rest is paramount. Fluid rehydration, antipyretic, anti-analgesic are recommended to relieve symptoms. Aspirin or other non-steroidal inflammatory drugs should be avoided in these patients. Associated bacterial infection can be treated with antibiotics. Infected persons should be protected from further mosquito exposure, especially during the first few days of illness. The risk of bleeding into the stomach can be decreased through the administration of antacids and other medications. The prognosis of yellow fever ranges in severity. Severe infections with internal bleeding and fever are deadly in up to half of cases. Prevention for vaccination, WHO strongly recommends routine yellow fever vaccination for children in areas at risk. The vaccine provides effective immunity within 1 week for 95% of those vaccinated. Single dose provide protection for 30 to 35 years or more, and probably for life. Children less than 9 months of age should go for routine immunization, or less than 6 months of age during an epidemic. Pregnant women, except where risk of infection is high, should also be vaccinated. People with severe allergies to egg protein. All right, so these are some of the contraindications in the patient that cannot be vaccinated, rather. Children less than 9 months of age or less than 6 months during an epidemic, pregnant women, people with severe allergies to egg protection, people with severe immunodeficiency and thyroid disorder. So it's contraindicated for vaccination in these patients, the group of people. For vector control, it's important to control mosquitoes spread and bites in the environment by eliminating grasses, standing water in rain gutters, clearing water ponds around the environment, clearing old tires, buckets, plastic covers, toys, or other containers where mosquitoes can breed. You can also use insecticides and repellents to control, vector control, and also mechanical method. This will involve the use of barriers like insects, site-treated nets, and fly traps. International health regulation requires proof for yellow fever vaccination for travelers arriving from or going to areas at risk. Travelers without proof of yellow fever vaccination may be quarantined for up to 6 days. Certificate of vaccination is valid for a period of 10 years, beginning 10 days after vaccination. Thank you very much for listening. Good morning, consultants, senior registrars. My continued presentation on dengue fever. Dengue virus is the most predominant vector-borne viral illness in the world and also be transmitted by the Aedes aegypti mosquito. WHO says some 2.5 billion people, two-fifths of the world's population, are now at risk from dengue fever, from dengue, and estimates that there may be 50 million cases of dengue infection worldwide every year. Epidemic is more in 100 countries. So the history in China, it was discovered in between the year of 265 to 420 AD, in French West Indies 1635, Panama 1699, Jakarta 1979, Cairo 1779, Philadelphia in 1780. These are the years when it was discovered. In 1989, first definitive case was reported by Benjamin Rush. No, then it was known as black-born fever. The world's largest epidemic was known to occur in Cuba in 1981. Incubation period of dengue fever is between 3 to 14 days, but commonly between 4 to 7 days. Fever comes within 8 days of after mosquito bite. If the infection is treated on time, mortality rates get reduced, and these mosquitoes lives near human habitat where they breed in even cleanest water. More severe forms of dengue can be fatal if unrecognized or poorly treated. For transmission, Aedes mosquito becomes infected with dengue virus when it bites a person who has dengue or dengue fever. After a week, it can transmit the virus while biting a healthy person. For about a week, it can transmit the virus while biting a healthy person. Dengue cannot be spread directly from person to person. So, under these factors, is younger than 12 years of age, female, commoner in white people as well. So, the symptoms are for my dengue fever, intense frontal headache, fatigue, muscle and joint pain, vomiting, reduced appetite. Can also have skin rash. Patient can also be present with bleeding from the nose, frequent vomiting of blood, excessive thirst, difficulty in breathing, and panting. And for severe cases, patient can present with petechiae, purpura, ecchymosis, gingival bleeding, nasal bleeding, gastrointestinal bleeding, hematemesis, melena, hematuria, even increased menstrual flow for women. So on a test we can perform, so as tourniquet test, by inflating a blood pressure curve to a point in midway between the systolic and diastolic pressure for 5 minutes. A test is considered positive when 10 or more petechiae per 2.5 centimeter square is noticed. In dengue fever, the test usually gives a definitely positive test if it's greater than 20 petechiae sites noticed. The test may be negative or mild positive during the phase of profound shock. So on the signs, you know you can suspect patient having dengue if they present with abdominal pain, which can be sustained and intense, persistent vomiting, abrupt change from fever to hypothermia with sweating and prostration. Patient can also present with restlessness, somnolence. In severe cases, it could present as even encephalopathy, hepatic damage, cardiomyopathy, severe gastrointestinal hemorrhage. The treatment for this is not specific. However, supportive measures are only recommended for now, which include adequate hydration, antipyretic. However, we avoid the use of NSAIDs and vasoprene, aspirin in these cases. Free resuscitation, very much paramount. Blood or platelet transfusion for patients who have bleeding disorders or who are anemic. Treatment with corticosteroids should not reduce the mortality with dengue fever. Ribavirin very weak in vitro and in vivo activities against flavivirus. So ribavirin antiviral agent is not trusted in this case. Treated dengue fever is associated with 3% mortality rate. Untreated dengue fever is associated with 50% mortality rate. For Lassa fever, which was first described in 1969, outbreak was noticed in Nigeria in 1970 and in Liberia it was noticed in 1972. In Sierra Leone, outbreak was noticed between 1972 to 1973. And Nigeria and Liberia had the highest cases with about 59 cases, making about 50% mortality. While in Sierra Leone, it was about 16% mortality that was noticed, with highest case of 441. For it was estimated to range between 200 to 400,000 cases per year in West Africa, causing about 5,000 deaths per year. 4% of survivors come down with deafness, and up to one third have some hearing loss. Fever, sore throat, and vomiting are one of the commonest outcomes you can get in these patients. Ribavirin started in the first 6 days of infection can reduce mortality. Lassa fever virus, epidemiologically found in many rats, can spread to humans by rats urine. Spread person to person by direct contact to these rats. About 20%, about 20 imported cases from Africa have been seen. And then it's important you consider ribavirin prophylaxis when there is exposure. Treatment is still supportive and ribavirin treatment. Marburg hemorrhagic fever. Marburg virus is a single-stranded, unsegmented, enveloped RNA virus that is morphologically identical but antigenetically distinct from Ebola virus. It's a new family Flaviviridae. Marburg virus named after the town in Germany where some of the first cases were described. Its reservoir nature remains unknown, and the most recent case of Marburg virus disease occurred in Kenya in 1987. The mode of acquiring natural infection with Marburg is unknown, and treatment is basically supportive as well. Thank you very much. These are my references. Thank you.